getting to learn these movement patterns, right? So I think there also has been a culture shift to, let people know that lifting when you're young is okay. It's healthy. It's not going to stunt your growth because that was the biggest myth growing up, right? And it was do not lift any sort of weight. But we're seeing now that your youth and kids, that's a prime opportunity and window for kids to, learn good movement patterns, start to build baseline muscle and strength, and then just, continue that once they get to university and higher levels of competition.
Welcome to the Athletic Edge podcast. I'm your host, Liam Evans, strength and conditioning coach and owner of Evans Performance. This is a podcast tailored for athletes, coaches, and parents interested in every facet of athletic development. Join me and guests from around the world as we dive into game-changing tools and expert insights covering strength training, performance enhancement, and long-term athletic development strategies. Uncover the keys to elevate your athletic potential, drawing from trusted resources to safely and effectively navigate your training and build your athletic edge. Welcome back to the show. Today, we are very lucky to have on Nikki Garcia, who is a physiotherapist with the Toronto Raptors. Thanks for coming on, Nikki.
Thanks for having me, Liam.
So before we get into any kind of the nitty gritty, do you want to tell people how you ended up in the position that you are today? Maybe a little bit about your background as well.
Yeah, sure. So I did my undergrad at McMaster University here in Ontario, and then did my physio school at Western University. After graduating, I did a sport physiotherapy fellowship with the Fowler Kennedy Sport Medicine Clinic there, where I worked pretty heavily with collegiate sports and athletes. I continued to work in sport medicine private practice settings after my fellowship, and then just saw a job posting for the Raptors 905, which is the G League affiliate team for the Toronto Raptors. I ended up getting that job, and then from then, just through the years, elevated up to the Toronto Raptors, and have been working here since.
Nice, that's awesome. Um, so I realize this is going to be kind of a very general question, and you could take it wherever you want to go. But what would you say is your overarching or 10,000 foot view of your approach as a physiotherapist?
I think I would say that it is to keep people as active and engaged as possible, and allowing them to become independent with their own, rehabilitation and medical management approach. So I don't often like to tell people you can't play, you can't do
Hmm.
this, you can't do like that's you're not going to hear that from me. I'd rather find ways to modify and adapt what they're doing for a short period of time until they could eventually get back to what they want to be doing. Unfortunately, some people just have bad luck with genes and injuries, and they're forced to kind of stop being part of one of their passions. But if there's ways we can find lateralizations where, those people and athletes are still getting fulfilled with their activity engagement, their competitive nature, I just want to keep people as active as possible.
Yeah, and I think, correct me if I'm wrong, but in some of the research I did, had something where you said, if a healthcare professional essentially prescribes you to stop doing everything, stop lifting or playing or anything like that, and doesn't provide an alternative, that might be a sign that you may want to go to somebody else. Could you expand on that?
Yeah, that was, I can't remember who posted it, but it was something I reposted. But essentially, where it comes to my approach and philosophy, it's as healthcare professionals, we have to analyze the risks, assess risk, and then discuss with the patient what their risk tolerant level is. And I don't think the answer is ever to just stop doing something.
Hmm.
And a lot, especially with the sport athletic population, majority of your rehab should be exercise based. If they want to get back to sport and you're on the table and they're just stretching you the entire time or doing some soft tissue massage, like that is also not okay because that massage we know is not going to be getting you back to playing and tackling athletes on the
Hmm.
field. Very much exercise based approach, very much do what you can approach. And if anyone tells you to stop doing something, you just evaluate it with a critical eye, I would say.
Yeah, and I find, especially as a strength coach with the population I work with, sometimes an athlete could have an injury to their big toe and they'll want to, or parents if it's a youth athlete, want to completely stop everything, and I'm trying so hard to get people to understand, that even if there's something that we can't do for, say, your right foot, there's a whole rest of your body that we can hopefully still get stuff out of, and obviously you're getting so much more benefit, even just systemically from trying to continue working out, or whatever it is. So when I go back to kind of your approach and things like that, obviously I don't know if it's old school or just some physiotherapists do it one way, some do it another way. But would you say you lean more to the side of maybe not doing 3 by 12 banded clamshells and maybe going more into, actually loading and finding a way to progressively add some forces and get back to that return to play?
Yeah, 1,000%. I've always said physiotherapists should probably have some sort of level of strength and conditioning background knowledge, especially if you want to work in sports. You have to know your training principles and those guidelines. And if you're building strength, 3 by 12, 3 times a week, or 3 by 10 is not doing it,
Yeah.
right? You need to lift heavier weights. You need to, if you're lifting heavier weights, then you can't do 12 reps. You got to bring it back down to 4 to 6 reps. That being said, I do think when we are introducing new movement patterns, things that people might not be well at doing, 3 by 12 has a place in prescription, right? You
Yeah.
just have to look at the intention of what you're doing and why you're doing it. As long as you have that background knowledge, then I guess you can argue anything that you're doing, but it just has to have sound reasoning.
Yeah, exactly. And in your population, which now would be mostly, if not all, basketball, what are some of the major injuries that you're seeing and that you're having to have to rehab from?
I would say basketball, your most common injuries are probably ankle sprains. You'll see some knee tendinopathies, whether that's quad or patellar tendinopathy, and then probably lumbopelvic. And I know lumbopelvic is kind of broad, but they kind of sometimes come in one. So anything with the pelvic girdle or your low back, because that requires a lot of core strengthening. Um, and some mobility there, depending on the person. Yeah, so I'd say those are the three typical areas we commonly see.
And what are some of the strategies, whether it's with the Raptors or at anybody, that you're using to, I guess, first, hopefully try and not prevent the injury, but reduce the risk of it happening. And then once we get past that, maybe we can look at kind of day zero of the injury and what that looks like of going from the injury happening to return to the court.
Yeah, I think injury risk and like prevention is interesting because I don't think we can ever say definitively that this program or something is going to minimize your risk of sustaining that injury. Um, what it boils down to really and what the research says is like training strategies. So you want to make sure that the athlete is prepared for the demands of the sport that they're going to participate in. And a lot of times right now we'll talk about load management in basketball, and we want to minimize this yo-yo effect. So
Hmm.
where your chronic load, you're basically trying to develop your base of your baseline measures to match that of the sport. And when you get too much too fast over the chronic baseline load, or too low because you didn't do anything for the next couple days, that's where we start to get some injuries and changes. You want to maintain a certain level of chronic load. Um, yeah, so I think just trying to make sure that the athlete is built for the activities they're going to be doing on court.
Gotcha. And then from the site of the injury, is it first? Obviously, it depends on what injury it is. But first into the treatment room, and then are you trying to get them moving as quickly as possible? I say this because I think some people that maybe don't know as much, maybe still rest ice compression first 4 weeks, this, that, and the other. Could you go into that a little bit?
Yeah, so typically the flow is, yeah, we might do some hands-on treatment, some manual treatment if we deem that it's necessary, and then you're getting them in the gym, doing some exercises with them. So we'll take an ankle sprain, for instance, and say it's an acute ankle sprain within the first few days.
Hmm.
So they're probably pretty painful. Their mechanics are probably inhibited. So we're just trying to stimulate that neuromuscular system with a lot of balancing, a lot of proprioception, range of motion to tolerance. Um, and then at that point, again, in the acute phase, they're probably not doing anything on court, but maybe they can. Maybe they can stand around and just do some form shooting. So
Hmm.
I'm not opposed to, like, again, not shutting them down, just seeing what they can do based on where they're at in their rehabilitation. And then in terms of the rice principle, uh, honestly, I don't think it's that bad. At the end of the day, it's short, it's easy to remember. General population, it's not going to hurt people at the end of the day. You're resting, you're icing, compressing, and elevating. There's nothing wrong with that. When you talk to other medical professionals, obviously it's going to be nuanced in terms of injury recovery and what is probably best practice. And there was a pretty good editorial written by the British Journal of Sport Medicine about a few years back. Uh, they basically created this new acronym of peace and love. Uh, I can't truthfully, I can't remember every
Yeah.
single one
That's a
of the
long one.
acronyms for that, but the general consensus of it, it was like early mobilization, relative rest, protective weight bearing. It's not telling you guys to not move. And that, again, if you could write that in a short protocol or short acronym that people could remember, great. But because healthcare and medical is, there's a lot of, it depends. There's
Yeah.
a lot of individualization. That's where seeing your medical professional and your physio is really going to help you. But for the general population and you just don't know what to do right away, you know what? Throw rice at it. It's not going to hurt you. It'll get you by for the next few days. So I'm not against it.
And would you, as far as just return to play, and because for people that maybe don't have full access to a medical team, obviously not everybody plays for the Raptors. Um, how do they? How can, for instance, because this is aimed at more youth athletes as well, if a parent of a youth athlete gets injured, say they've gone through those first phases, how can we talk to them about how they want to think about possibly returning to the chaos that is whatever sport that they're doing?
Yeah, that's a good question. Because a lot of times, again, in private practice, and even if you're lucky to see a physiotherapist in private practice, they don't have the ability to talk to coaches as
Exactly.
frequently or being involved in that on court return to play or on field return to play process. So, the best thing I could say is just make it a graded exposure or progressive ramp up to return to play. Um, so, if you have sustained an injury where you're completely out of competition and it's taking you about 3 weeks, think about it as okay, if it took you 3 weeks, think of it logically. If it took you 3 weeks out, how do you expect to return to play in 2 days?
Hmm.
So, kind of your return to play process has to be relative to the amount of time that you were out. If you were out for 1 day and you're able to walk the next day, maybe you could return to play relatively fast. But I think thinking about it as a bigger picture, and then when they are returning to play, just be smart about it. So you didn't participate in practice 1 day, so maybe you return to a non-contract practice.
Yeah.
So if we're talking about basketball, let's get some shots up. Let's get some relocating drills, some finishing drills without defense. See how that feels. Then the next practice, maybe incorporate, as long as that went well, if that first stage went well, progress to the next stage. Okay, maybe do some controlled live play or drills with your coaches and players. And then that goes well, maybe try some limited minutes in your next game. I think, again, it's just making sure you can check off the boxes that are required of playing the sport in full competition prior to going back to competition.
Yeah, because I find especially with anyone that isn't, associated with a academy or anything where they're gonna have full-time, essentially, medical assistants, it's almost like sit out until they deem that they're at least at a percentage, 90% where they can go back to a full practice. And that's what I find is happening the most. And then, within even that practice or a few practices, they're finding that they're getting re-injuries or even more, little niggles and things like that. And I do think that just comes from not understanding the graded exposure going back into sport. And also having the strengthening side along with that. So they might be just fully resting for 2 months and then try and go straight back into the sport. So as anything, yeah.
No, 1000%. I agree. And especially in youth, depending on the program that you're part of, strength and conditioning isn't part of your program.
Yeah.
Like I remember when I was playing competitive basketball, I wasn't on a national level, but it was still fairly competitive. It was probably one of the highest provincial leagues that I was part of, and there was no strength and conditioning program. And the first time kids in Canada are usually exposed to organized strength and conditioning culture is university. And at that point, you've kind of missed the big milestones of when you're growing and getting to learn these movement patterns, right? So I think there also has been a culture shift to, let people know that lifting when you're young is okay. It's healthy. It's not going to stunt your growth because that
Yeah.
was the biggest myth
Yeah.
growing up, right? And it was do not lift any sort of weight. But we're seeing now that your youth and kids, that's a prime opportunity and window for kids to, learn good movement patterns, um, start to build baseline muscle and strength, and then just, continue that once they get to university and higher levels of competition.
Are you able, I know it's not exactly your population, but are you able to provide any sort of information on these quote unquote growth related injuries? So Osgood and severs, anything like that? Because especially with the way that youth sport is these days, I'm finding a lot of kids are coming and either having these or what they deem to be these kind of injuries.
Yeah, so the most injuries that you'll probably see in youth and kids are these um, growing related aches and pains. So Osgood Schlatter's and Sever's disease. Those are all self-limiting conditions, and by self-limiting, it means you could actually play through the pain.
Mhm.
Um, the biggest thing as a healthcare professional is the education that we provide them and letting them know that you will have a good prognosis out of this, that you're not going to have this pain forever. And this is the kind of the window that this presents because you've just been jumping a little bit too much, playing 6 times a week of volleyball or basketball. And so it's just one, the age that you're at and the activities that you're doing. So trying to modify your activities, maybe get stronger as well, maybe target other areas. If you're jumping a lot, you're probably loading that anterior chain a lot, so maybe doing some posterior chain exercises. Um, the other one that you'll probably, which actually brings me to the other reason kids will get injured, is those uni sport players that are again
Yeah.
playing the one sport 6 to 7 times a week with no break, and that's where you get overuse, which again boils down to some education around um, the kids playing other sports, how long kids should be probably playing in a sport at that age, and having that 3 to 4 months of rest in between a season rather than going from one season to the next season immediately. So most injuries in kids, if it's not traumatic, have good prognosis, like that those diseases, like those conditions you said, like severs and osgoods. So it's just the education around it and trying to affect change in the kids activities.
Yeah, and I find it's like you said, it is with those injuries more about pain management than anything else because, like you said, it doesn't really. We're not necessarily going to make it worse. You're just going to have flare ups from time to time, and there might be periods where okay, you do come out of practice, or you only participate in half of practice because the final game that you're playing or anything like that is a little bit too painful. But on the as somebody who also had those sort of injuries, it does eventually go away. It is stubborn, and it does sometimes take longer for some. I've known kids that do have to deal with it for quite a while. Um, but just doing everything else, good nutrition, good sleep, obviously, and hopefully participating in some form of strength and conditioning program can help all these things. But at the end of the day, it is, yeah, one of those really annoying injuries that some kids do end up just having to deal with.
Yeah, exactly.
Um,
Exactly.
Also, with that, I had a lot of people ask me even before this podcast about kind of the tendonitis situation, and even tendonitis versus maybe like a patellofemoral pain or things like that. Could you maybe explain the differences or and what exactly tendonitis is, and then we can go more into it?
Yeah, so I think even in the word itself, tendinitis, tendinosis, tendinopathy, there's a lot of different nuances between those. And so if we're saying tendinitis, it's inflammation of the tendon. So we boil down to the anatomy of it. A tendon is what attaches bone to muscle. And so When you get inflammation of it, you're often typically overloading that tendon and producing a little bit too much force than that tendon can handle. And so, how do we build up the capacity of the tendon? So, research shows that isometric strength can help that. Eccentric strengthening and loading can help build the tendon strength. Your plyometric training, all of those good things to build tendon health to avoid that itis or the inflammation that can come with it. So, tendinosis is just chronic inflammation. The term I like to use is tendinopathy, which just means that there's something going on with your tendon, which is just a broader explanation because, yeah, you can have pain in your tendon, you could have inflammation in your tendon, but what is the strategy that we're going to do to make it better is load it. So, with patellofemoral pain, now that's a little bit more broad. It's typically a more umbrella condition where there's multiple factors, intrinsic and extrinsic factors, to say that you have something going on with your knee, the front of your knee. So I think prior early ages, it used to be that you had patellar maltracking. So the way your kneecap sits at the front of your knee, it just keeps shifting to the side. And it's causing some irritation at the joint underneath the kneecap, and then you get pain. But I think we've just realized over time with research that it's a little bit more complex than just a maltracking. And when we're strengthening, a lot of it, I think, with treatment for patellofemoral pain, it used to be glute focus. Okay, watch the knee valgus, posterior chain strengthening, and all of those are good strategies. But sometimes the person with patellofemoral pain also just did too much too fast. So you give them a little bit of time of relative rest to calm things down, and then you just load them back up. So figuring out what factors affect the patellofemoral pain. So are they maybe flat-footed and maybe doing too much valgus stress onto their knee? Are they a little bit more quad dominant than hamstring dominant? So you might need to balance out those stressors. Um, do they have limited range of motion? Just all those things.
For someone that deals with maybe chronic knee pain, chronic tendonitis, is there anything that they can think about doing? Is it as simple as when it's flaring up, you just have to kind of cool out a bit, or is there something that they can try and do to maybe help that, or is it like you said, if you're out for maybe 3 weeks, you're probably going to take 3 weeks to come back from that?
So isometrics has shown really good promise and
Do you want
results
to,
for
for
pain
people that may
management.
not know what that is, do you want to quickly explain it?
Yeah, for sure. So isometrics is creating a force output without the joint actually moving. So if we're talking about a knee, then if you're going to do a quad extension, so if you think of those machines where you like push your shin into the little foam pad there, you are trying to generate about 75% to 80% of your max voluntary contraction, pushing that into the little pad without the knee actually moving. So you're not doing a full quad extension where you're extending your knee, you're just creating some tension to get that quad firing without movement. Another way people do this is wall sits. That's a like perfect example of people doing getting an isometric contraction without the joint actually moving. And so holding a isometric contraction, so a wall sit or a quad extension for about 45 seconds, do it for 3 rounds, has shown to really help pain modulation, which might not fix things in the long term, but can get you to be more functional and with less pain immediately after.
Yeah, I was going to say it can almost have that analgesic effect where if you are about to do something and you are in a little bit of pain, these isometric exercises have been shown to hopefully take away some of the pain that you may experience. And the great thing about them for anybody listening is you don't really need to be you don't need a whole bunch of equipment to do a lot of isometric things. You can, do a wall sit, isometric split squat, anything, which is pretty easy to do at home if you are experiencing any pain. How can they? So obviously, 3 by 45 seconds, whatever it is. Say they're doing that for a couple of weeks. What's some ways that they might be able to kind of progress any of these? Would you just hold dumbbells, add weight, add time?
Yeah, 100%. I would then add some weight, make the movement a little bit more difficult. So if they're doing a double leg quad extension, do a single leg quad extension, get them into a baby Bulgarian squat rather than a split squat so that that rear foot is elevated, and they're loading more of the front leg. And then, yeah, adding weight, loading it is get some dumbbells on you. Maybe do it on using a trap bar. Um, those are great ways to progress it. And then when we're talking about tendon health, I think you would also, once you're past the pain stage and it's not as painful and you tolerate it, switching it up, doing tempo, eccentric works like slow load and then a concentric quick second. Um, those are the principles that again physios and strength coaches just live by. That's their bread and butter to help adapt change to the body.
Do you ever use, and maybe not in this situation, but in general, like a more of an overcoming style isometric, or is that more if they're healthy, then they can think about some of those things?
I would typically say if they're healthy and have no prior tendon issues, or if they have tendon issues, like they're well past like their most recent flare up, um, are definitely good strategy to implement in those to again just build tendon health.
Yep. How does it work? Maybe even in the Raptors setting, where you know you're working with obviously the strength and conditioning team and everybody, because it's a whole program. But how does that kind of trade off or handoff work? Or if somebody is injured, you're essentially on the floor with them during their workouts, no matter what.
Yeah, I think when you work in a multidisciplinary setting like a team, you're very fortunate to have the strength coaches near you, and so we work like hand in hand. If we're rehabbing a player, the very beginning of the player's injury, I would say, is front loaded by the physiotherapist. So we're doing pain management strategies. We are getting their range of motion back. We're getting basic strength and function back. And then they eventually progress into this next realm where, well, actually, let's go back to that first realm is I'm focusing on those things, but the strength coach is still focusing on other things. So maybe it's a lower body extremity, lower body injury, and they're still lifting their upper body, and
Mhm.
they're still keeping up their cardiovascular through an airdyne bike, an upper body bike. And then as they progress through their rehab, I start to decrease the amount of work that I'm doing with them because they've restored all their range of motion, they've restored all of their function, and then now you're trying to increase their other capacity that is sport specific, so their plyometrics, their force development, and that's where our strength coach kind of takes lead, and then I'm more supplementary of okay, so what do they need for their warm up? Do they need some range of motion mobs? Do they want to do some therapeutic exercises just to kind of prime the body, like kind of like a warm up or an activation? And then the strength coach kind of takes on the other training stuff of progressing them.
Do you guys have any baseline tests that you run with your players? And less so on maybe the strength and conditioning side, so less so, a max strength exercise, but I don't know, we could go into your thoughts on even like FMS or balance, Y balance, or things that you would traditionally or typically hear about in a physiotherapy setting.
Yeah, so um, I think the current baseline testing are just movement screening that we do. We don't follow necessarily like a functional range conditioning or FMS screen because those are just concepts of how you would do an assessment, right? If we can pick and choose what we want to do. On the sports science side, you definitely do a lot more baseline testing, but from a physio standpoint, you're just really checking your general range of motion. Is there anything, any limitations in their range of motion that might impact them playing? Um, and go from there because as we've kind of discussed earlier is that injury risk is so multifaceted and multifactorial and contextual. So for me to say like, oh, you have limited range of motion in your ankle, you are definitely going to have an ankle injury in the past, we can't guarantee that, right? But we can identify areas of emphasis and areas that we might want to work on that maybe might help them reduce their chance by a little bit. So I think the more important part are getting the baseline strength sport science measures like your force plates and your external load, basically.
Is one of the most important things for you guys to kind of understand about your players also their previous history of injuries? And from that, is there anything that gets done if somebody has, chronic ankle sprains or knee pain, lumbar pelvic pain, anything like that?
Yeah, I think that's definitely all relevant.
Yeah.
And again, prior injury is one of the biggest risk factors of a future injury. So if you had it in the past, there's a good chance that it can come back. So understanding what has happened when they were in the AAU circuit or when they were growing up, did they have a surgery for, I don't know, a tibial plateau fracture or whatever it may be, all of those increase their risk for future injury. And that's where we need to kind of mitigate and implement strategies to reduce that risk.
How do you guys approach asymmetries? Because there's obviously some, I guess, different schools of thought on asymmetries in general, and obviously as humans, we are inherently asymmetrical. But when it comes to maybe having an injury, some atrophy happens in the muscle, things like that. How do you guys look at that?
So, like you said, asymmetries are normal and natural, and you're never going to get a symmetrical athlete, particularly when your sport is like the intent of you scoring is based off one hand. So, right-handed basketball player, a right-handed, right-footed kicker, you're naturally going to have these asymmetries. That being said, if you constantly load, so when you're playing and you're constantly feeding into those patterns of the asymmetries, you could potentially get into some injury risk there. So I think when we try to train people, we try to get them into a neutral posture, as neutral as possible, knowing that they are going to overload that pattern of asymmetry when they play, because you know what, that's how sports is. Like
Yeah.
no one is symmetrical when they play sports, and you need that dominant movement patterns to be able to perform. But as long as you're making sure you're not neglecting the other side when you're especially lifting or doing maybe therapeutic exercises, that's where you're really, again, if you move it, what's the phrase, you don't move it, you lose
You
it.
lose it. Yeah.
So if you keep feeding in these patterns of the asymmetries, then you're going to run into some problems. So you need to make sure you are doing things to the best of your ability to feed the symmetrical pattern. But again, you're not trying to change it because you need to be asymmetrical to play sports.
Yeah, exactly. That's one of the big things is that people come to like, oh, he's really strong on his right leg, his right arm, anything like that. And it's like, oh, it's probably what makes him one good at his sport. But yes, there is a point. We can look at it, but it's also very inherent. Have you had to deal with any kind of ACL rehab recently or in general?
I used to do ACL rehabs when I was in private practice, and since going into professional sports, I haven't had to see a fresh ACL through the beginning to the end. But I've had a lot of experience, especially in uh, when I was doing my sport physio fellowship. There were a lot of orthopedic surgeons, and the referrals were always coming into our clinic. So um, prior time.
Yeah, because that's something as well that you hear a lot with getting the injured leg back to whatever 90%, 95% strength of the non-injured leg, or whatever, if it's a triple single leg hop, anything like that. What are your best practices as far as coming back from an ACL for somebody again that is doesn't have a holistic team around them, and maybe they've gone through surgery, they've gone through maybe early stage with a doctor or physio, and now are trying to return to playing their either recreational sport or they're maybe a youth athlete.
Yeah, so I think there's just going to be continuous research in that field of what is actually predicting um, risk of re-injury. Is it the asymmetry? Um, or what is going to help quality of life and performance, because they're two different streams really when we look at it. And there's a lot of protocols and testing that you can do to get measure asymmetries, but that doesn't, again, guarantee that you're not going to re-injure that side or the other side. It's just making a objective number to make it feel more comfortable for you to return to play. And where I've seen issues, thankfully I've never had someone re-rupture under my caseload, but what it shows is that you go back too soon.
Hmm.
So there's fluctuating days like, okay, is it 9 months? Is it 12 months? And it really takes time, especially after you've had such a extensive surgery for you to get back to your normal strength, your normal movement patterns, the neuromuscular training, factor in recovery through all of that. Um, and I think another emerging topic, which might not be relevant to my field right now, but for other populations, is ACL. Once you have an ACL injury, I think the automatic thought process is, "Oh, I'm having surgery." And there's increasing more evidence that shows that you can actually be extremely functional and can return to sport going the conservative management route and not doing surgery. So I think that's a really interesting topic because, again, I went to physio school and at the time it's like, yeah, ACL surgery, ACL send to ortho, like that's just automatic. I still think you send to ortho, but what's happening now is that once you start to do an analysis of the risks associated with the person in front of you, so what sports do they want to get to? Do they plan on playing sports the rest of their life? How old is the patient when they sustain the ACL injury? And you're factoring and analyzing all of those things to decide, okay, actually, you might be good to just do conservative management and not do surgery because your outcomes are going to be the same, especially for the sports that you want to get back to. And then the other thing I also see is some people think that, you know, the sooner the surgery, the better. But that's also not the case. You want to make sure you have a quiet, sound knee before you go into surgery. Like the stronger you go into surgery, the better you come out. And it's shown like the earlier you have surgery for any, like an ACL, uh, the increased risk for post traumatic knee arthritis. So you want to make sure before you go the surgery route that you have your full range back, knee strength. And once sometimes, especially when I was seeing patients, when they were building up that strength back and going, preparing basically for surgery, they didn't really notice a difference in their life aside from not playing the sport that they were used to. So if you again consider that going through that process, staying on that rehab track for a year and then going and obviously within that time frame doing small bouts of sport specific training and stuff, you might not need surgery, which can be a hot take, but
I mean, it's funny
um,
that you say that because my my sister tore her ACL like a year and a half ago and opted not to have surgery, and she's back to essentially doing. She tore it skiing, I believe, which she doesn't do often. But yeah, she's back to running normal sports, working out, everything. So yeah, and I've had a few people that I've heard recently that have not had surgery, but obviously we hear about the athletes and they're almost all of them, if not all of them, are having surgery, and also we hear about them coming back in record times or whatever it is, and it's like, all right, they have a little bit different situation than us. And actually also with that, for somebody that is coming back from an ACL rupture, is pain something that's normal going through that return to play process, and if so, how much is too much, how much is it okay?
that's so
Not to be a
yeah,
loaded question.
that one can be tough because um I've read a couple studies that shown the difference of progressing through rehab, pain tolerance exercise or pain absence exercise. And there have been different results. So it's shown that people who do pain tolerance rehab exercises um, actually build strength faster and stronger once they get past through it. But pain absence, I think, kind of return a little bit sooner. So my policy is that it's if you avoid pain for your whole life and you never know how to deal with it, that you expect it to be such a bad thing that it's going to limit you probably longer than you expected. Early mobilization, getting used to some soreness, getting used to some pain to desensitize the tissues and letting you know because pain is an alarm system. It's not a hurt. It doesn't mean there's absolutely a lot of like damage going on.
Damage, yeah.
It's just exactly. It's just telling you that something's going on with your body at that point. It's an alarm system letting you know that something. And if you can just say, all right, alarm system, that's okay. I'm going to continue going through this. You're going to get, again, like some studies have showed, you're going to get stronger than if you had just limited your pain or stopped exercising because of your pain.
Yeah, exactly. And there are, I mean, it's confusing for us who both work in, essentially the physical performance fields. It's confusing with the amount of things that you hear and the research done, and so many things are out there and different ways. And honestly, a lot it does seem like, as long as you're not doing it quote unquote wrong, there are many right ways that could take you to the same end goal. But yeah, even for us, it gets gets like there's a lot of information. It can get confusing. So I think it's helpful for people to hear that there's not just one way to do things, and yes, there are best practices, and we want to listen to those. But also, one thing I had somebody ask me about was, and you mentioned it with common injuries that you deal with, and that's the lumbopelvic side of things. What type of injuries are you seeing? Because there's also in the field a lot about back pain and lower back pain right now, and how we want to deal with and manage that, and to stabilize or to flex or to extend to this to that. How can you best kind of put that into words for any of our listeners?
Yeah, good question. Lumbopelvic, I like to group them again into one. You'll typically, if you just look at the lumbar spine, you'll get lumbar spine injuries. So your facet joints, your disc issues, or just mechanical low back pain, which is what most people experience. You don't need to get nitty and gritty of like what specific structure is injured. It
Yep.
could just be generalized
Non-specific.
to low back pain.
Yeah.
Yeah, non-specific. And then you get into the pelvic injuries. So you could get osteitis pubis. Um, you can get some groin adductor, some inguinal hernia, sports hernia, or core muscle injury, I believe is the correct term right now. Um, so it's those are the specific injuries that you'd get with the lumbopelvic area, but I think when managing it, the treatment is very similar when it's core strengthening. And I think nowadays people are really understanding what the core actually is, and it's not just your six pack abdominis at the front there, and it's more of a full 360 structure that you need to train. And I think again, once you start to that's why I group it because most of my low back pain and most of my osteitis pubis people or they're getting similar treatment plans. They're how do you engage your deep inner core? How do you engage it while doing functional movements? And are you getting the range of motion and the load transfer the way that you would do? And you're not getting pain with that. So, yeah.
Yeah. Perfect. And one other thing, you said something, and I don't know if it was you or maybe you reposted it, but along the lines of when you're doing an exercise, you really have to essentially pay attention to the area that you're trying to engage. Is this something along, what did you hear about mind muscle connections, things like that? Or,
I think it was, for a campaign that I was part of, just to talk about the mind to muscle connection. In general, I just mean that it's the neuromuscular connection. I think knowing your body and having body awareness is really important in sports. But when you're playing sports, you aren't thinking, okay, my glute is extending as I raise this left leg up, and like you're not
yeah,
thinking of it that way. But when you're training people and say they have discrepancies and deficiencies in, say, glute extension or hip external rotation, this is where cueing becomes really important. So your internal or external cues of how you're going to get that person to engage that area of the body. I'm not getting them to be I'm not getting them to be that specific to engage that area because I think it's going to help their performance. I'm doing it so that they can build body awareness. So that when I get them to do a Bulgarian split squat or I get them to do a split lunge, they are actually engaging those muscles rather than overloading their typical movement pattern. So when it goes back to again the asymmetries, people will have they might they're either anterior dominant, they just naturally have adopted that pattern. And if we want to be intentional with our exercise prescription and we want to target the posterior chain, you need to be able to cue them so that they can engage that area. And that's that mind to muscle connection that we want to try and emphasize and that neuromuscular circuit. So the more that you are feeding that pattern, the easier that it gets to activate and fire that pattern. If you never actually pay attention to firing it, say you're doing a squat, you could do a squat multiple ways, but you might be doing a squat anteriorly or posteriorly, and you keep saying, do this squat, but you never get the athlete to actually pay attention how they're doing it. Again,
Hmm.
you just might be feeding into the faulty pattern.
What do you? So I get a lot of my athletes will come to me after either being to maybe a physio or even just, a sports masseuse or anything like that, and they'll come back and say, "Oh, so and so said I have, a weak core or weak glutes." Those are the 2 that I hear all the time. Meanwhile, I'll test their glutes, glutes are pretty strong. Their core, I'm like, "How exactly did they determine you have a weak core?" Things like that. Could you speak to maybe those 2 cases? And I think it also may go along with the nervous system and mind muscle connection.
Yeah, language is really important as healthcare professionals, especially when we're dealing with athletes, because you use the wrong word, you say tear, and they
Yeah.
immediately imagine something, right? And
Mhm.
so when you tell someone that they have a isolated weak right glute or a weak core, again, they imagine certain things, and obviously not to critique like the physio's advice or anything like that, because when you again when you test it, they're actually functionally strong in those areas. Um, it might just be the way that they were taught something uh, they were taught of how why a condition happens.
Mhm.
So again, if we go back to the patellofemoral pain syndrome, a lot of the time it was like, oh, knee valgus. So how do you get knee valgus? Because your glutes poor, your glutes weak, and so they'll attribute that as to why this person's having knee pain. But most times in physio clinics, you don't have like a handheld dynamometer or you're not doing a force plate testing or anything like that to actually measure is that glute weaker than the other glute. You're just doing manual muscle testing. And our hands, as good as they can be, aren't good at measuring strength. Like you could get general strength again, but if I'm a small girl, if I have a guy who's 200 pounds, yeah, they're going to overbeat me. Anything they do is going to be 5 out of 5 strength
Yeah.
on a manual muscle test,
Yeah.
right? So I think sometimes we just fall into habit of saying like, oh yeah, you have a weak glute because we know that, oh yeah, patellofemoral pain, it's because you go into knee valgus, so we need to automatically strengthen your right glute. Like, I think sometimes it could be said out of that context.
Do you use, or what are your thoughts on kind of the corrective exercise road, that some people use a lot of?
Yeah, I definitely do corrective exercises. I might not call them corrective exercises, but it again falls back into the asymmetries, right? And trying to make sure we are loading the players' bodies holistically and not going into not feeding into their asymmetrical patterns or their default patterns. And uh, so I'm going to say, for example, a right handed shooter often will have more limited in right rotation because they're always in this forward position. So my corrective exercise for that person is to do right rotation, to get maybe do some open books, maybe do some half kneeling rotations. Again, not just to make sure that we're not always emphasizing this pattern that they're always going to get into. So I think corrective exercises, the term has kind of been thrown out a lot. I think it's true. I just necessarily won't call it that. I would just call it therapeutic exercises.
Mhm. Perfect. I don't wanna take up too much of your time, so last question, I know you're busy, and this actually I got from somebody who asked me to ask you, but it's basically along the lines of fascia and slash the IT band and what it is. Can we stretch it? Can we roll it out? Can we all those sort of stuff. So if you wanna quickly touch on that before we finish.
Yeah, for sure. It's you hear it all the time. My
All the
IT
time.
band's tight. Can you work on my IT? It's tight. It's tight. And the IT band, again, anatomically, we just need to look at the structure. It is a piece of fascia or connective tissue that attaches to the outside of your knee, and its muscular attachments are your hip flexor and your glute. And so fascia is all throughout our body, but our IT band is probably our strongest and thickest piece of fascia, and it has very minimal movement because it's meant to help create that lateral stability in that lateral chain. And so when I can't remember who posted it, but I think they said that you needed like 9,000 newtons to deform the IT band like
Mm,
1%.
yeah.
And like that it you cannot stretch it more than it already is. But what people feel are the because it's a like if we think of it as a rope that doesn't stretch, what you can get are some glute tightness or hip flexor tightness that again pulls the IT band in a certain like again presses it against your quad muscles and then making it feel tight. So though your probably best route to attack your IT band tightness, roll out your quads, roll out your glutes, roll out your hip flexors, do some hip mobility, do some knee mobility. Um, it's such a nuance. Like, if someone tells me that their IT band is tight, I'm not going to argue them. I'm not going to tell them that they're wrong, because you could do the exact same thing. Roll it out, do some strengthening exercises to affect your flexibility and mobility, um, and then maybe see why you're getting into that pain. But yeah, the IT band does not stretch. It does not move.
Yeah, I find people come in and say it's tight, or I'll just ask. They'll say they're injured, and you ask, what's wrong? I say, oh, I have an IT band injury, and I'm like, well, what exactly does that mean? But yeah, so advice, most likely gonna have to work around the IT band to fix anything, quote unquote, with the IT band. But anyway,
Yeah, for sure.
we'll wrap things up there. Thank you so much for taking the time to do this. This was great, and hopefully provide a lot of information. Is there anywhere you want to leave anything if people want to reach out or have any other questions to reach you?
Yeah, for sure. I just use my Instagram account to answer any questions that people might have. I eventually get to them. Sometimes I'm not as fast, but I will get to them. So you can reach me on Instagram, nikkig.pt. If you have any other questions, I'm open to answering them.
Perfect. And yeah, we'll leave all that in the show notes so people can just see it. But thank you again. I appreciate your time.
No problem. Thanks for having me, Liam.